Picture this. It is 6:47 in the morning. You did not drink coffee. You did not argue with anyone. You did not rush. You simply woke up, walked to your bathroom, wrapped the cuff around your arm, and watched that number climb to a place it has no business being at this hour. 154/91. And your first thought is, what did I do wrong last night? The answer is almost certainly nothing you cooked, nothing you drank, nothing you forgot to take. The answer is probably how you slept, not how long, not how deeply. The physical position your body spent the last 7 hours in, and the silent chain of cardiovascular events that position triggered every single hour while you believed you were resting. I'm Dr. Alan Miller, and after 18 years treating cardiovascular risk in older adults, I have watched this connection go unnoticed in waiting rooms, in cardiology referrals, and in the quiet frustration of patients who do everything right and still cannot get that morning number under control. Today, that changes for you. By the time we finish this video together, you will understand exactly why sleep position becomes a cardiovascular variable after the age of 65, in a way it simply was not at 40. You will know which specific positions are silently stressing your heart, your blood vessels, and your kidneys while you sleep. You will understand the role of a nerve in your neck that most people have never heard of, and how the angle of your pillow can either protect it or impair it every single night. And I am going to give you a 5-step protocol you can begin tonight. Not next week, tonight. Stay with me, because what I need to tell you about midway through this video affects roughly 1 in 3 people watching right now, and almost none of them have ever been told. Here is the truth that almost never gets communicated clearly in a routine appointment. Your blood pressure is not a single fixed number. It is a living, rhythmic signal that rises and falls across a 24-hour cycle, a pattern governed by something called the circadian rhythm of blood pressure. In a healthy cardiovascular system, blood pressure dips naturally during sleep, typically 10 to 20% lower than your waking baseline. Doctors call this the nocturnal dip. It is not optional. It is not a bonus. It is the window during which your arterial walls decompress, your kidneys filter under reduced load, and your heart muscle itself recovers from a full day of work. Now here is what happens as we age. After 65, the autonomic nervous system, the part of your biology that manages heart rate, vessel tone, and pressure regulation without any conscious input from you, begins to lose its calibration. The signals become slower, the feedback loops less precise, and the nocturnal dip that should happen every single night starts to shrink, or disappear entirely. When blood pressure fails to fall during sleep, doctors call this non-dipping hypertension. And studies have shown that non-dippers face dramatically higher rates of stroke, heart attack, and kidney deterioration than people whose pressure behaves normally, even when their daytime numbers look identical. The frustrating reality is this. Your physician takes your blood pressure at 2 in the afternoon. They see a controlled number. They adjust medication based on that number. And meanwhile, from midnight to 5 in the morning, your cardiovascular system may be under a level of strain that no one is monitoring, no one is treating, and no one is connecting back to the pillow under your head. This is not a failure of medicine. It is a gap in the conversation. And today, I want to fill that gap. Let's begin with the position that the majority of older adults default to over time: sleeping flat on the back. On the surface, this seems like the rational choice. No joint compression, neutral spine, no awkward twisting. And for many musculoskeletal concerns, it has genuine merit. But for blood pressure in an aging cardiovascular system, back sleeping initiates a predictable and measurable chain of problems. When you lie flat on your back, gravity does something immediate. It redistributes blood volume toward the center of your body, specifically toward your thorax, the chest cavity that houses your heart and great vessels. Your heart suddenly receives more blood returning from the lower body than it does when you are seated or standing. This is called increased preload. And to manage that increased volume, your cardiovascular system has to work harder. In a younger, elastic arterial system, this adjustment is handled seamlessly. The vessel walls expand and recoil. Pressure stays regulated. But after 65, arterial stiffness, the gradual hardening of the vessel walls due to decades of normal use, blood sugar fluctuations, low-grade inflammation, and reduced elastin, means that compliance is limited. The walls cannot expand as readily to absorb the increased volume. The result is often a subtle but sustained rise in overnight blood pressure. Now add the pillow equation. When a back sleeper uses a pillow that is too flat, the neck falls into hyperextension, meaning the chin tilts upward and the back of the neck shortens. When the pillow is too high, the chin is pushed toward the chest. Both positions place mechanical stress on a structure that has a profound, underappreciated influence on your cardiovascular regulation, your baroreceptors. These are pressure-sensing nerve endings embedded in the walls of the carotid arteries in your neck, specifically in a region called the carotid sinus. Their job is continuous and critical. They monitor the stretch of the arterial wall, interpret that stretch as a pressure signal, and send that information directly to the brainstem. When pressure rises, the baroreceptors tell the brainstem to slow the heart and dilate the vessels. When pressure drops, they signal the opposite. This reflex, called the baroreflex, is one of the primary mechanisms your body uses to keep blood pressure within a safe range, especially during sleep when you have no conscious control over the process. Here is the problem. When neck position during sleep compresses, stretches, or mechanically distorts the carotid sinus, baroreceptor signaling is impaired. The reflex that should be quietly protecting you throughout the night becomes unreliable. Blood pressure that should be corrected is not corrected. And that uncorrected pressure accumulates hour after hour in your vessel walls. This mechanism is well documented in research on carotid baroreceptor sensitivity in older adults. It is rarely discussed with patients, and it is directly influenced by the height and firmness of the pillow you sleep on every night. Let me tell you about Bernard, 73 years old, a former accountant, meticulous, organized, the kind of man who had tracked his blood pressure in a notebook for 6 years. His readings had been stable for most of that time. Then, about 18 months before I saw him, his morning numbers began climbing, consistently. Not dramatically, but the trend was unmistakable. He had not changed his diet. He had not changed his medications. He had not changed his exercise routine. What had changed was his pillow. His wife had bought him a new one, a thick memory foam pillow that was considerably higher than what he had used for years. It pushed his chin forward and down during back sleeping, placing his neck in sustained flexion for 7 hours every night. We identified the issue in a single consultation when I asked him, almost as an afterthought, whether anything in his sleep environment had changed. He replaced the pillow with a low-profile, contoured cervical pillow. Within 3 weeks, his morning readings had dropped an average of 14 points. 14 points from a pillow change. But back sleeping, even with the wrong pillow, is not the most dangerous position for blood pressure after 65. What I am about to describe is far more serious. The most cardiovascularly destructive sleep pattern I see in older adults is back sleeping combined with undiagnosed obstructive sleep apnea. Sleep apnea is a condition in which the soft tissue at the back of the throat, the tongue, the soft palate, the uvula, collapses partially or completely during sleep, blocking the airway. The brain, detecting a drop in oxygen, fires an emergency adrenaline signal that forces the airway open. The person gasps or shifts, oxygen is restored, and the cycle begins again. This happens not once or twice a night. In moderate to severe cases, it happens 30, 40, 60 times per hour. Each event triggers a surge of epinephrine, adrenaline, that spikes blood pressure dramatically. In some cases, readings during an apnea event reach 200 over 100 or higher. The spike lasts only seconds, but the arterial damage it causes is cumulative and progressive. Here is where sleep position becomes the accelerant. When you sleep on your back, gravity pulls the tongue and soft palate directly backward, narrowing the airway at its most vulnerable point. Back sleeping increases the frequency, duration, and severity of apnea events in virtually every patient who experiences them. And this matters enormously because sleep apnea is dramatically underdiagnosed in the over 65 population. Conservative estimates suggest that 35 to 40% of older adults have clinically significant sleep apnea. The majority have never been evaluated. They snore. Their partners mention it. They wake up tired, and they assume it is just aging. It is not just aging. It is a cardiovascular event happening dozens of times per night. Vera was 69 when she came to see me, a retired nurse, someone who, by her own admission, knew more about health than most patients, but had been applying that knowledge to everyone but herself. She had been managing blood pressure with 2 medications for 4 years. Her cardiologist was considering a third. She mentioned, during a routine review, that she had started sleeping in a recliner because her lower back hurt when she lay flat. She had been doing this for almost a year. The recliner kept her partially upright, but she was still predominantly on her back, and she was still snoring, loudly, according to her daughter, who stayed with her occasionally. I ordered a home sleep study. The results showed 47 apnea events per hour. Her oxygen saturation was dropping to 81% at the lowest points. We referred her for CPAP therapy and began positional training, specifically left side sleeping. Within 2 months of consistent CPAP use and positional change, Vera's evening cardiologist visit produced a reading that genuinely surprised him. Her blood pressure was controlled on 1 medication for the first time in 4 years. The third medication was never added. Before we go further, and this is important, if you are currently taking blood pressure medication, please do not make changes to your dosage or stop any medication without speaking to your physician first. Everything I am sharing today is educational guidance meant to complement your medical care, not replace it. If you believe sleep apnea may be a factor in your blood pressure, bring it up at your next appointment and ask about a sleep study. Now let me tell you about the position that research consistently points to as the most protective for cardiovascular health in older adults: left side sleeping. This is not a new recommendation. The research supporting left lateral sleeping for cardiovascular and lymphatic health has been building for decades. But the reasons why it works are worth understanding, because when you understand the mechanism, you are far more motivated to actually make the change. First, airway geometry. When you sleep on your left side, the tongue and soft palate are no longer falling backward by gravity. They shift laterally, maintaining a more open airway. Apnea events decrease in frequency. Oxygen saturation improves. The adrenaline spikes that batter your arterial walls throughout the night are reduced. Second, cardiac geometry. The heart is not centered in the chest. It sits slightly to the left, and its axis is oriented in a way that left lateral positioning supports the natural geometry of ventricular filling. Some cardiovascular researchers describe left-side sleeping as reducing the mechanical load on the heart by improving the efficiency of blood return from the lower body, specifically through the inferior vena cava, the large vein that carries blood from the legs and abdomen back to the right side of the heart. Third, lymphatic drainage. The thoracic duct, the primary vessel of the lymphatic system, runs along the left side of the spine. Left lateral sleeping may facilitate lymphatic flow and the clearance of metabolic waste products from tissues during sleep, supporting a broader environment of reduced inflammation and vascular stress. None of these effects are dramatic in isolation, but across 7 hours a night, 365 nights a year, they compound into a meaningful cardiovascular difference. Robert was 76 years old, a former high school football coach. Big man, barrel-chested, the kind of patient who sat in the exam chair like he owned it. He had been a committed right-side sleeper his entire life, right shoulder down, right arm tucked. He told me it was the only way he could fall asleep. Robert had mild heart failure, an ejection fraction in the low normal range, and his overnight fluid retention was a persistent management challenge. His ankles were swollen most mornings. His morning blood pressure was elevated. His cardiologist was adjusting diuretics quarterly. We had a long conversation about cardiac geometry and left-side sleeping. Robert was skeptical. I asked him to try it for 30 days, starting with a body pillow in front of him to prevent rolling back onto his right side during the night. He came back in 6 weeks. His ankles were less swollen. His morning readings had dropped. His cardiologist, at his next quarterly visit, noted the improvement and reduced his diuretic dose slightly. Robert told me he still did not love sleeping on his left side, but he did it anyway, because the data was right there in his cuff readings every morning. Now, what about right-side sleeping? For the majority of older adults without significant structural heart disease, right-side sleeping is considerably better than back sleeping from a blood pressure perspective. The airway remains more stable than in the supine position. The central blood volume redistribution is less pronounced. Overall, it is a reasonable choice. However, for individuals with congestive heart failure, significant mitral or tricuspid valve disease, or conditions that affect right-sided cardiac function, right lateral positioning can reduce the efficiency of ventricular filling. The heart's anatomy, when compressed against the right side of the chest cavity, may not perform optimally. If you have been diagnosed with any of these conditions, this is a specific conversation worth having with your cardiologist. The general principle holds for most people. Left is better than right, and right is better than back. But your individual anatomy and diagnosis matter. Dorothy was 71 and had been diagnosed with moderate mitral valve regurgitation 3 years before I saw her. She slept on her right side, as she had for decades, and she was experiencing increasing nighttime breathlessness. Nothing dramatic, but a subtle awareness of her breathing that was waking her 2 or 3 times a week. Her cardiologist had adjusted her medication twice in the preceding year. When we discussed sleep positioning in the context of her valve condition, she had never been advised on the topic. We introduced left-side sleeping with a gentle transition protocol, starting with a 20-degree incline wedge pillow, and worked with her cardiologist to monitor the effect. Her nighttime breathlessness improved within 3 weeks. It did not disappear. Her valve condition remained. But the positional optimization removed one unnecessary stressor from her overnight cardiovascular workload. There is one final mechanism I want to cover before we move to the protocol, and it is the one that surprises people the most, because it involves something as simple as the height of your mattress head. Positional elevation of the head of the bed, not stacking pillows, which, as we have discussed, can worsen neck position and impair baroreceptor function, but actual elevation of the bed frame or mattress at the head end, using risers or a wedge system that tilts the entire sleeping surface. Even a modest elevation of 4 to 6 inches produces measurable cardiovascular effects. It reduces the degree to which blood volume pools centrally during sleep. It decreases the effort required for the heart to manage overnight preload. And in patients with mild gastroesophageal reflux, which is extremely common over 65, and which is itself associated with autonomic nervous system arousal and disrupted sleep, Elevation reduces nighttime acid events, improving sleep continuity, and, by extension, cardiovascular recovery. Several small but consistent studies have also shown that mild head elevation during sleep can reduce snoring frequency and improve oxygen saturation in older adults with mild sleep-disordered breathing who are not yet CPAP candidates. It is not a substitute for sleep apnea treatment, but it is a meaningful, supportive measure that carries no risk and zero cost beyond a set of bed risers. Here is what I want you to take from everything we have covered today. Sleep is not a passive state. It is the most active recovery window your cardiovascular system has. And for 20, 30, 40 years, most of us were never taught that the position we sleep in has a direct conversation with our heart, our blood vessels, our kidneys, and the nerves that regulate all of them. You went to bed last night believing rest was happening, and for most of you, some version of rest was. But for a significant number of people watching this, people with uncorrected sleep position, undiagnosed apnea, the wrong pillow, the wrong side, the cardiovascular system spent those 7 hours not recovering, but compensating, not resting, but working. That changes tonight. Not because I am asking you to overhaul your life, but because the gap between where you are and where you could be is in many cases as small as the difference between your right side and your left. Step 1. Begin sleeping on your left side. If you have never done this and it feels unnatural, use a body pillow or a rolled blanket placed along your back to prevent you from rolling onto your back during the night. It will feel unfamiliar for the first week. That is normal. Give it a genuine 2-week trial before you evaluate whether it is working. Most people notice a difference in their morning readings within 10 to 14 days. Step 2. Audit your pillow. For side sleepers, your pillow should be firm enough and tall enough, typically 4 to 6 inches, to fill the space between your shoulder and the side of your head, keeping your cervical spine level with the rest of your spine. If your shoulder is being pushed upward by the mattress and your neck is still bending downward toward it, your pillow is too thin. For back sleepers, use a contoured cervical pillow, not a flat standard pillow, and not an oversized one. The goal is to maintain the natural inward curve of the neck without pushing the chin toward the chest. Step 3. Elevate the head of your bed by 4 to 6 inches, using bed risers under the headboard legs. Do not achieve this with extra pillows. The goal is a gentle tilt of the entire sleeping surface, not a bend in the neck. This reduces central blood volume redistribution, supports lymphatic drainage, reduces reflux events, and improves mild sleep-disordered breathing. Step 4. If you snore regularly, if you wake during the night feeling short of breath or startled, if your partner has ever noticed you stop breathing during sleep, or if you wake up consistently fatigued despite a full night of sleep, ask your doctor about a home sleep study. Home sleep studies are now widely available, affordable, and do not require a lab visit. Undiagnosed sleep apnea is one of the most common and most correctable drivers of resistant nighttime hypertension in adults over 65. Treating it may accomplish more for your blood pressure than adjusting medication dosage. Step 5. Implement a morning and evening blood pressure tracking habit, and do it properly. Take your reading at night, seated, after 5 minutes of quiet rest, before bed. Take your reading again in the morning, within 30 minutes of waking, before coffee, and before significant movement. Track both numbers for 2 consecutive weeks, and bring that log to your next appointment. A morning reading that is consistently 15 or more points higher than your evening reading is a clinically meaningful finding. It tells your physician something your office visit cannot show them, and it opens a conversation about nighttime cardiovascular stress that might otherwise never happen. Your heart has been working without a break since before you were born. Every beat, every night, every year. The least we can do is give it a sleeping position that works with it instead of against it. What you learned today is not complicated. It is not expensive. It does not require a prescription. It requires a body pillow, the right pillow height, a set of bed risers, and the decision to roll to your left side tonight. That is it. And it might be the most important cardiovascular decision you make this week. I want to hear from you. Leave a comment and tell me, which side do you sleep on? Left, right, or back? And here is the question I really want you to think about. When you measure your blood pressure in the morning, is that number noticeably higher than when you measure it in the evening? Write your answer below, because your pattern might be the thing that helps someone else in the comments finally connect those dots. If someone you love has struggled with blood pressure that does not respond the way it should, a spouse, a parent, a sibling, please share this video with them. Not as a channel promotion, as an act of care, because this is the kind of information that lives in research journals and specialist conversations, and rarely makes it to the kitchen table where it is actually needed. And when you are ready for the next piece of this puzzle, the video coming up next covers the single mineral that more than 40% of adults over 65 are deficient in, and how that deficiency directly impairs the body's ability to regulate blood pressure during sleep. It is a 10-minute watch that will change the way you think about what you eat in the evening. I will see you there.